everyone, and welcome to Transformed Minds. This is the podcast where we explore the real world intersection of mental health, addiction, and transformative care. I'm your host, Dr. O, and with each episode, we take a thoughtful, practical, and evidence informed look at how we can improve psychiatric and addiction care from clinical settings to the community spaces we work in. And if you're new here, here's the vibe. We have our host RX, so it's just me and you, and we're breaking down the research and we're sharing what actually matters for our work. And we have our expert RX, where we bring in brilliant minds from the field, whether they're clinicians, physicians, researchers, change makers, policymakers, advocates. We bring them in and they share their expertise with us. And we have our lived RX. That's where the real life stories come in. These are people who have lived it, they have survived it, and they are reshaping the system because of it, right? Because of their experiences, they are experts and they're helping us make our system better. Today, it's a host RS. It's just me and you, and I am so glad you're tuning in. And remember, as always, this is not a clinical advice, it's for educational purposes only. Today, we're going to examine a randomized clinical trial that has reignited a serious scientific conversation about the treatment architecture of alcohol use disorder. We know that harm reduction helps, and we have to continue to optimize the medication that we use. What we're going to discuss today, it's focus on whether psychedelic compound psilocybin administered in a structured psychotherapeutic setting can meaningfully reduce heavy drinking. This episode is grounded in a 2022 randomized controlled trial that was published in JAMA Psychiatry by a research group from NYU, Dr. Bogenschutz and his colleagues. I'm not sure if I'm saying the name right. If I did not, I apologize. The question is whether psychedelics alter the neurobehavioral rigidity that defines addiction, and whether that alteration translates into measurable clinical benefit. Alcohol use disorder remains undertreated despite the FDA-approved medications we currently have. The American Medical Association has repeatedly emphasized the need for expanded evidence-based addiction treatment infrastructure. If psilocybin-assisted psychotherapy demonstrates durable reductions in heavy drinking, why can't we use it, right? The implications extend beyond just the novelty of it. They touch the workforce, reimbursement, regulatory oversights, and standards of care. So, today, we're going to analyze what the evidence shows and does not show. So, let's review the study that we're grounding ourselves in today. It's a double-blinded, randomized control clinical trial. It enrolled adults with a DSM-4 alcohol dependence diagnosis. The participants underwent a 12 weeks of psychotherapy. They received either 2 doses of psilocybin or an active placebo, which was a diphenhydramine. The primary outcome was the percentage of heavy drinking days during the weeks 5 through 32. The results showed significantly fewer heavy drinking days in the psilocybin group. Secondary outcomes showed higher rates of abstinence. Importantly, adverse events were transient and manageable within the structured setting when using psilocybin. So the findings in this randomized clinical trial of 93 adults with alcohol use disorder actually showed that the heavy drinking days over 32 weeks were significantly lower when you compare it to the diphenhydramine placebo, right? The difference in heavy drinking days was about approximately 13% points difference. This is clinically meaningful, especially in population with long-standing alcohol use disorder. When there's chronic alcohol use, this is such a significant outcome. And this was not psilocybin alone, right? It was psilocybin with structured psychotherapy. So the intervention is not simply just pharmacologic. There's experiential and relational parts of it. What the study is not showing us is that there's the long-term durability beyond 32 weeks. It does not establish any comparative effectiveness versus other available treatments like naltrexone or acamprosate. It does not clarify generalizability to community settings, right? So within the broader literature, early pilot work suggested feasibility and significant benefit. Mechanistically, psilocybin is a serotonin 2A receptor agonist, and it's associated with acute increases in entropy and downstream change in default mode connectivity. Addiction is characterized by a rigid, repetitive behavioral loops. So the theoretical premise is that psychedelic-induced cognitive flexibility will allow this restructuring of maladaptive patterns when paired with psychotherapy. However, the theory is one thing, but it's not implementation. Theory is very different from implementing what we're talking about. So the central question really for today is this evidence strong enough to justify integration into addiction treatment systems, right? Or is this just too much enthusiasm too early and we don't have that implementation aspect down yet? So, how is this clinically meaningful? What does the results really mean? The reduction is statistically significant and it's also clinically relevant because in addiction treatment, even modest percent reductions in heavy drinking days correlate with decreased morbidity, right? People are able to function better. And it decreased the amount of lost productivity, loss in functionality in their life. Yet, we must be able to contextualize the magnitude against existing treatment because we already have existing treatment. It may not be many, but we have them. So, if we're going to approve something new, is it better? Is it given the same effects? Or there has to be something. It has to be able to stand against what we already have, right? We know naltrexone that we have reduces heavy drinking days by smaller margins on average, but it is scalable and orally administered, right? We also have the long-acting injectable Vivitrol that we give for people. So when we look at psilocybin, it requires an intensive infrastructure. And the effective size matters, but delivery burden matters equally. When we look at just psilocybin and the effect the study is showing us, is it pharmacologic? Is it psychotherapeutic? Or is it a synergistic effect? And when we look at the intervention, it includes like preparatory and integration therapy, meaning that the psychedelic experience is hypothesized to enhance openness and emotional processing, right? So, like, without dismantling studies, we cannot separate drug effect from the psychotherapy amplification. So, for clinicians, this underscores that psilocybin is not a replacement for therapy. It may be a catalyst, right? Neurobiologically, psilocybin increases the cortical entropy and modulates the default mode network. Addiction is associated with these maladaptive salience, attribution, and compulsive reinforcement learning that emerging neuroimaging literature actually suggests that psychedelic-induced flexibility may disrupt that rigid reward prediction error loops that we have where we see. However, the direct mechanistic evidence in alcohol use disorder populations still remains limited. So we don't have enough research and studies to fully support this hypothesis. Ethically, psychedelic experience can induce like acute psychological distress, right? So screening protocols in trial excluded individuals with psychotic disorders and certain psychiatric comorbidities. In real-world settings, ethical deployment requires stringent screening, informed consent, and trained facilitators. When we look at policy right now, Psilocybin remains federally like a Schedule 1 drug, which means that there's no currently accepted like medical use and it has a very high potential for abuse, right? It's in the same class as medications like ecstasy, heroin, LSD, and there's currently like state level reforms that are emerging, and the American Medical Association has called for evidence-based addiction treatment expansion, right? So if psychedelic therapies become FDA approved, reimbursement structures and credentialing standards must evolve to help with that implementation and risk stratification. Implementation science will determine whether this remain like a boutique medicine or is going to be a scalable care. So let's take a look at a case. We have a 45-year-old man with severe alcohol use disorder, multiple failed trials of naltrexone, ongoing heavy drinking, no history of psychosis, and really motivated to change, right? When we look at this clinically, he meets criteria for severe alcohol use disorder. Evidence-based option like naltrexone, acamprosate, behavioral therapy, contingency management. He's tried some of them and it hasn't worked. Psilocybin-assisted psychotherapy may become an option if FDA approves it. Screening would exclude bipolar 1 and psychotic vulnerability, right? Decision making must really remain shared and evidence informed. System wise, access would depend on regulatory approval, insurance coverage, trained facilitators, structured monitoring. Because remember, it's psilocybin, so we really have to manage that psychological distress that can come with it. Without reimbursement parity, this risk widens disparity. So, for clinicians and trainees, how does this trial compare to the ones that already exist in? We see a smaller sample size, psychotherapy embedded active placebo, right? Long follow-ups. The psychotherapy embedded is a unique aspect of it into the psilocybin trial. There's an active placebo. There's longer follow-up than many pilot studies of 32 weeks, right? Are there any contraindications? This study is identifying comorbid psychotic disorders, unstable bipolar disorder, uncontrolled cardiovascular disease can all be contraindicators, right? Counseling a patient requesting for psilocybin today, you really have to clarify the investigational status, evidence-based risk, legal contacts, all of these things has to be clarified. If you're policymaker, should public funds really support psychedelic research? Why not? The evidence suggests that there may be some benefit to it, but we need rigorous studies. So the funding is justified, right? Could this reduce alcohol-related morbidity? We already see some potential, but we're going to have to scale it beyond the small sample size that we have. So it can be generalizable to a wider group of people, right? In a place where we're not getting treatment and we're not researching more treatment that is going to be beneficial, but somehow increase that disparity gap, widen the gap of access for people. We don't want to do that. And as we've talked about before, what safeguards are necessary? If you're a policymaker, train in standards. When you are approving these medications, you have to make sure that training standards are evolving with it, right? License and oversight, safety monitoring, because you don't want to approve something that then puts people at higher risk. We don't want to do that. So here's a mental model for you. Addiction is behaviorally rigid under a neurobiological constraint, right? Psilocybin may temporarily increase that cognitive flexibility. Psychotherapy directs that flexibility towards restructuring maladaptive immune system. But there are three components of this: biological disruptive of rigid networks, structured psychological guidance, integration into sustained behavioral change. Without any of these three, that model sort of collapses, and this is not going to help, right? So, in closing, the evidence shows promise and not replacement, right? So, we really have to understand the mechanism before the enthusiasm of all of this. We need more research and regulations to match what we're putting out there. Science is progress, but it's not a miracle therapy. We're progressing in the right direction. as we examine psilocybin and treatment-resistant depression and its implications for comorbid addiction and alcohol use and all these other things, we have to really make sure we're doing the best for our communities and we're safeguarding our communities. Thank you so much for listening. We're going to continue this beyond alcohol use disorder. In the next episode, we're going to see what are some of the literature with psilocybin and depression. Thank you for listening. But as always, stay ready, stay aware, and stay grounded.